Okay. Welcome, everyone. My name is Chris Hager, and I am the Health and Human Services Committee Chair for the League of Women Voters of Montgomery County, Maryland. It's a non-partisan organization that does not endorse candidates or support political parties. In accordance with our mission to empower voters and defend democracy, we sponsor webinars to inform the public on important issues. Nearly 74,000 adults and more than 8,000 children in the county do not have health insurance, and nearly 118,000 adults in the county are underinsured. The uninsured includes low-wage workers, part-time county employees, and small business workers. They are disproportionately people of color, as well as immigrants and refugees who are not eligible for many government programs meant to help close the coverage gap. Will state legislative action fix the problem? That's the question for tonight's presenters. Tonight's presenters will address. We will have an audience question and answer after the presentation. But first, some housekeeping detail. This webinar is presented by the League of Women Voters of Montgomery County. The meeting is being recorded and being live streamed by Facebook. The recording will be made available at a later date on our YouTube channel. Be sure to follow us on Facebook and Twitter, and subscribe to our YouTube channel, and turn on notifications for new updates. The audience will be muted during the webinar, and the chat box has been disabled for attendees in order to minimize distractions. After our speakers make their presentations, we will have a Q&A session. Questions will be visible as they are answered. We encourage you to ask questions, but want to remind everyone to be respectful of our speakers and each other. To submit a question, click on the Q&A button at the bottom of your screen, type your question into the box, then hit send or return. We will answer as many questions as time allows. The program is scheduled to end at 8:30 p.m. Now, I am pleased to introduce tonight's speaker. Vincent DeMarco is the president of the Maryland Citizens Health Initiative, a statewide coalition of faith, business, labor, professional, and community groups that advocates for affordable and accessible health care for all Marylanders. Joanna Fabian Marks is the Director of Policy and Plan Management for the Maryland Health Benefit Exchange. Established in 2011 under the Affordable Care Act, the exchange acts as a central government resource to help Maryland residents and small businesses to find affordable health coverage and explore programs to reduce the out-of-pocket costs. And finally, Dr. Sonia Bruton is the president and Chief Executive Officer of the CCI Health Services in Silver Spring, a nonprofit group health practice that treats patients of all ages, including refugees and gender nonconforming adults. Now it is my pleasure to invite Vincent DeMarco to begin tonight's program.
Thank you very, very much, Ms. Hager. And I really am a big fan of the League of Women Voters and have been so for a long, long time. Before I worked on the healthcare issue, I was a Maryland leader on gun violence prevention, and we made a lot of progress on that issue in Maryland, thanks in large part to the League of Women Voters. So thank you very much. And thanks for having me here with Johanna and Dr. Bruton. It's a great honor to be with them and with all of you. I would like to do a couple things today in this very, very important session. And first is to describe the successes we have made in Maryland. Ms. Hager was right to say that we have a problem in continuing all the number of people who are uninsured in Montgomery County and throughout the state. But first, we should understand that we have in Maryland and across the country made some tremendous progress, primarily thanks to the Affordable Care Act. Now, even before the Affordable Care Act was enacted in 2010 under President Barack Obama, we were making progress in Maryland. We raised cigarette and alcohol taxes, which reduced teen smoking and underage drinking, and used the proceeds from those public health revenue sources to fund health care for 100,000 lower income parents who were not eligible for Medicaid before that. So that was real good progress. But the big progress in Maryland happened thanks to the Affordable Care Act and President Joe Biden's Inflation Reduction Act, which is built on the Affordable Care Act. We have reduced the number of uninsured in Maryland by 400,000 over the last few years, thanks to those measures, from 13% uninsured rate to 6% uninsured rate. That is tremendous progress. We're about the 5th best state in the nation in doing this, and that is really a lot to be proud of. Now, not every state fully implemented the Affordable Care Act and made this kind of progress. It's very sad that many states are resisting implementing parts of the Affordable Care Act, particularly the Medicaid expansion. But in Maryland, we have, and under Democratic and Republican governors, we have made great progress. And one of the main reasons is we have the very best health benefit exchange in the nation. I'm thrilled you have Johanna here who will talk from the exchange, but they are really terrific in what they do. And it is not easy to fully implement the Affordable Care Act, but they're doing it and they're doing it well. And our General Assembly has built on the structure that the Affordable Care Act created to do even more than other states have done. We have a reinsurance program, which I'm sure Johanna will talk more about, which keeps premiums low for folks on the Affordable Care Act. We in 2019, we enacted 2 landmark laws, which are really doing a lot to expand healthcare coverage and make healthcare more affordable. The one sponsored by Delegate Jocelyn Peña-Melnick, now Chair Jocelyn Peña-Melnick from Prince George's and Anne Arundel County, and Senator Brian Feldman from Montgomery County. It was something called the Easy Enrollment Health Insurance Program. That was the first of its kind in the nation, which allows people at tax time to check a box to see if they're uninsured, and if they are uninsured, check another box to say if they want to start a process to get themselves insured. Very innovative new approach to getting people health care coverage. And that has gotten over 10,000 new people covered by healthcare, and we want to build on that. And we're working with new Comptroller Brooke Learman to implement an auto enrollment piece of that to get even more thousands of folks enrolled through easy enrollment. And I'm proud to say that 9 other states have followed our lead in enacting easy enrollment, and our wonderful Senator Chris Van Hollen, who of course from Montgomery County, has proposed national easy enrollment legislation. So easy enrollment is a great way to move forward. And then after the easy enrollment law passed, Delegate Lori Charkoudian, Senator Jim Rosapep got a law passed which has an easy enrollment kind of approach when people file for unemployment insurance. They're asked in Maryland, are you uninsured? And if you are, here's a way you can get insured. And thousands of people have gotten insured that way. Very, very exciting. Also in 2019, Maryland was the first state in the nation to enact a prescription drug affordability board. We can't have quality, affordable health care for everybody while high-cost drugs are gouging us. We need to make sure that high-cost drugs are more affordable. Our prescription drug affordability board was the first of its kind in the nation and is now on track to make high-cost drugs more affordable, first for state and local governments, and we hope after further legislation for all of us. And several other states have enacted prescription drug affordability board laws, and that law was also first introduced by Senator Brian Feldman, Montgomery County, and Chair Pena Melnick. And Brian Feldman is also a chair of a committee. They're both chairs now, but they're both wonderful legislators who have led the way on those efforts. Those efforts have made a big difference. Now, so you could say that we've made progress in covering people, in making healthcare more affordable through the Prescription Drug Affordability Board, and in achieving something very, very important, which is reducing health inequities. There are really terrible inequities in our health care system. And that's why we worked in 2021 with Senator Antonio Hayes of Baltimore City and Delegate Jazz Lewis from Prince George's County to enact a First Nation Health Equity Resource Communities Act, which is providing millions of dollars of state money through the Community Health Resource Commission to fund local community-based efforts to reduce health inequities. Very, very important. We have to do that. So all these measures that we've enacted in Maryland are making great progress. And in addition, a couple of years ago, Senator Brian Feldman, again, from Montgomery County, and Delegate Ken Kerr from Frederick County, got enacted a unique law, first in a nation of its kind, youth subsidies law, providing $20 million a year for 2 years to help young people afford health care who can't afford it even with the subsidies under the Affordable Care Act. And 45,000 people have been helped by that law, 17,000 new young people enrolled. So I laid all that out to say we have done a lot and made a lot of progress, but we need to do more. In his inaugural address, Governor Wes Moore recognized that there are hundreds of thousands of remaining uninsured in Maryland, and we need to get them insured. We can't leave them behind in healthcare coverage. Thank you, Governor Moore, for making that a priority. And we're working to build on the progress we've made in the past in the 2023 session and beyond. We have a resolution, and you can go to healthcareforall.com/resolution to see it, where we have gathered over 300 faith, community, labor, business, and healthcare groups from across Maryland to unite behind a three-pronged approach to go from 6% uninsured to 0% uninsured. One is to find people who are eligible but unenrolled right now through programs like the Easy Enrollment Program. We think there are tens of thousands, maybe over 100,000 Marylanders fit in that category. We want to get them enrolled. Second, we want to provide additional subsidies like the youth subsidies I mentioned for people who can't afford healthcare even under the ACA. And third, we want to remove immigration barriers. Ms. Hager referred to that. It is just unconscionable that there are many Marylanders and people across the country who can't get healthcare coverage because of their immigration status. So those are our three goals. And we are going to make substantial progress of those three goals in the 2023 session. We won't do it all. We won't go to 0% uninsured. We will make progress, but we will build on this progress in the next few years to achieve that goal. What are we doing this session? One, there is a bill by Senator Brian Feldman and Delegate Ken Kerr to continue those youth subsidies, and that's likely to pass. Going to continue them for another 2 years. Then there's going to be a study to see whether it should continue further. But we're thrilled that that bill, which is passed the House and the Senate, and now it's got to be past each other body, has to confirm what the other body did and then go to the governor. So that's number one. Number two, Delegate Laura Tracutian and Senator Malcolm Augustine from Prince George's County I've put in legislation that would automatically enroll people who are now on the SNAP, or used to be food stamp program, and who are eligible for Medicaid but not enrolled, and just automatically enroll them. That is really exciting. That could find another 60,000 people across the state and get them enrolled. A very important way to achieve our first of our three goals of automatically enrolling people who are eligible but unenrolled. And then I told you, mentioned the subsidies. We also have a legislation to make sure this Prescription Drug Affordability Board can do all it needs to do. And we want to remove those immigration barriers. So legislation by Delegate Bonnie Cullison of Montgomery County, who's now Vice Chair of the Health and Government Operations Committee, and Senator Clarence Lamb from Baltimore and Anne Arundel County would allow immigrants to get coverage under the Affordable Care Act and through the exchange. And that legislation has passed the House and is going to the Senate. And there's legislation that passed the Senate and is going to the House to create put together a study with Delegate Bonnie Cullison and Senator Ariana Kelly from Montgomery County, and have put in, and Shelley Hedelman from Baltimore County have put in legislation to do a study on how to remove immigration barriers for people who are eligible for Medicaid and make sure we have the subsidies for people who have immigration barriers. So these measures we are very hopeful will pass this year, and they will continue the progress that we have made. We have made up till now, but we can't stop there. We have to continue to move forward, and after we pass these measures this year, make sure that we build on this progress. And how do we plan to do that? Number one, as I said, is make sure that the easy enrollment law of 2019 is fully implemented with auto enrollment. That has not been done so far, but we are working closely with the exchange and with Comptroller Brooke Learman to make sure that happens. Because when we do that, we can find and enroll the tens of thousands of people who are eligible for Medicaid right now, but not enrolled. Combine that with this new SNAP bill, and we will make a lot of progress in that direction. Then again, there are people who don't have enough resources to afford health care, even with the subsidies that are there under the ACA and the under the Affordable Care Act. And the new youth subsidies are a big step in that direction, but we may need additional state subsidies. Massachusetts is the #1 state in the country for providing healthcare coverage, and they're at 3% uninsured, unlike our 6%. And one of the main ways they achieve that is through additional state subsidies. So we want to look closely at that. One thing I want to mention, though, that's very, very important. The Affordable Care Act subsidies were terrific, but President Biden and Vice President Harris built on those subsidies under the Inflation Reduction Act. And the additional subsidies in the Inflation Reduction Act, which was enacted last year, are very, very important in expanding healthcare coverage. Those are going to expire in 2025. President Joe Biden, in his budget that he announced this year, would make those subsidies permanent. We need to support President Biden to make those subsidies permanent, either through this budget this year or in 2025 or whenever it is. We can't let those subsidies lapse. So those are very, very important. And third, we need to make sure that immigration barriers are removed. The law that is about to be enacted, we hope, is a very important step in that direction. And it allows the exchange, it requires the exchange to get some federal waivers that are necessary to allow immigrants to get coverage under the ACA. But it does not, as it's written now, provide the subsidies that are necessary, because unfortunately, federal subsidies are not available for people who have immigration barriers, who are undocumented or here for less than 5 years with documents. And we're going to, at some point, need to find resources to provide the same subsidies for those folks that other Marylanders have in an equitable way so that they can get the healthcare coverage they need. And let me close with this. When we do this, go from 6% to 0% uninsured, we will be doing a very important moral achieving a very important moral goal. Because as Martin Luther King said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. However, in addition, we are helping all of us, because when uninsured people go to the hospital and can't pay for their care, uncompensated care program covers that. And who pays the uncompensated care fund? All of us through our premiums. So it is what former House Speaker Mike Bush called a hidden healthcare tax that we all pay every day. Let's reduce that hidden healthcare tax. Let's reduce uncompensated care by going from 6% to 0% uninsured, and we will all be better off. And thank you very much, the League of Women Voters, for having me here.
Thank you very much, Vincent. Next, I'll invite Johanna, Davey, and Marks to present.
Thank you, and I will go ahead and share some slides. Let's see, and I think that is, where are we? Sorry, just one moment. Okay, can you see my slides?
Yes.
Wonderful. Okay. So thank you for inviting me to present today. As was mentioned, I am the Director of Policy and Plan Management at the Maryland Health Benefit Exchange, and I have the good fortune to go after Vinny. So we covered a lot of territory around what's happened and what's on the docket legislatively in the state. I thought with my time, I would touch a bit on how we're implementing some of the initiatives that Vinny mentioned, also share some data on Montgomery County, the folks that we're covering and the uninsured still remaining, and just start off by giving a quick overview of the Maryland Health Benefit Exchange for those who might not be familiar with us. So the Maryland Health Benefit Exchange is an independent unit of state government. We've been around since shortly after the Affordable Care Act passed. And our state agency is called the Exchange, but the platform that we operate is Maryland Health Connection, or MHC, as we call it for short. Maryland Health Connection is our website. We also have a mobile app and call center. And through these venues, we offer Maryland residents a one-stop shop to explore health insurance options. We're really the place to go if you don't get insurance through your employer or through, say, Medicare or another government program. If you're looking for coverage, Maryland Health Connection can help get you connected. And we also determine eligibility for financial assistance, whether that's for Medicaid or for the financial premium subsidies that Vinny mentioned for people who buy private plans who make too much to qualify for Medicaid. Through Maryland Health Connection, we serve nearly 1 in 4 Marylanders. Most Medicaid enrollees come through our platform to enroll over 1 million, and most enrollees in the individual market, which is the term for folks who buy their own private coverage rather than getting it through an employer. So that number is actually a little old. We've got over 180,000 individuals enrolled in private coverage now on Maryland Health Connection. Our overall mission is to improve the health and well-being of Marylanders by connecting them with high-quality, affordable health coverage, and our vision is to get there for all Marylanders. Just a snapshot of enrollment in Montgomery County. The top bullet point is qualified health plans or private plans. We've got about 40,000 Montgomery County residents enrolled in private plans through the exchange, and about 165,000 individuals enrolled in Medicaid. And that chart there shows the breakdown of enrollment by race and ethnicity in both private coverage and Medicaid, with the top bar in each section showing the statewide totals, and then the lower bar showing how Montgomery County compares. And just overall, I think we see that there's lower white enrollment, higher Hispanic enrollment, and other categories are more or less kind of in line with the state averages. When we turn to look at the uninsured in Montgomery County, and we do a regular analysis of census data, which is our best source of data to estimate uninsured individuals. And unfortunately, our most recent data is 2019 due to the pandemic. More recent data was just released, but we haven't had the chance to complete our analysis of it yet. But as was mentioned, we estimate that about 74,000 Montgomery County residents are uninsured. That's about 7%. Of that 74,000, a little more than half could enroll in coverage through Maryland Health Connection. A little less than half would not be able to enroll due to their immigration status, as Vinny mentioned. Maryland Health Connection can only enroll legally present individuals, and that's federal regulation. Looking total at the state, we've got about almost 360,000 individuals uninsured. That's the 6% uninsured rate, of whom about 260,000 are legally present and eligible to enroll in coverage through Maryland Health Connection. When we look at that 40,000 individuals who are uninsured but could enroll now, we see that we estimate 60% of them would be eligible for financial assistance. So that's where the programs that Vinny mentioned to go out and try to really make it easy for uninsured people to get connected to coverage can help make a difference, because they could be getting free or low cost coverage now, but for whatever reason, we haven't been able to reach them yet. And then here's a breakdown of uninsured in Montgomery County, just a little bit more detail, a breakdown by race and ethnicity, and also legal status. So the green portion of each bar shows individuals who are legally present and could enroll through Maryland Health Connection, and the blue portion of each bar shows those individuals who, because of their immigration status, would not be able to enroll through Maryland Health Connection. You can see that the largest impact there is on Hispanic residents of Montgomery County. I won't spend a lot of time on some of these items that Vinny already mentioned, but I have a few slides here on what we're working on in terms of access, increasing access, and improving affordability. So as Vinny mentioned, we've gotten thousands of individuals enrolled through our partnerships with other state agencies, where we add a checkbox to their forms for individuals to indicate they're uninsured and consent to have their information shared with the exchange for assistance enrolling. So very excited about that. Really revolutionary around the country to be doing this. Maryland's really leading the way in this regard. And as Vinny mentioned, there is legislation in process that would direct the exchange to apply for a waiver of the federal prohibition on allowing individuals with certain immigration statuses to enroll through the exchange. So if that passes, we would then be working over the coming years to make Maryland Health Connection available to all individuals. Now, that doesn't mean that the financial assistance would be available to all individuals. Federal financial assistance still would not be available. So that would be a future thing for the state to consider, is how to make coverage not only accessible, but affordable to all residents. As Vinny mentioned, we operate at the exchange, the state reinsurance program. That's a federal state partnership that brings in a significant amount of federal funds to help to reduce costs in the individual market where people are buying their own coverage. Through that program, we've reduced premiums by about a third compared to where they would be if the program didn't exist. So it's had a really substantial impact on making coverage more affordable. And in fact, Maryland has the cheapest top three cheapest plans on the exchange compared nationally. So it's just been incredibly successful in getting those premiums down. And we'll be extending that through 2028 thanks to legislation that passed last year. We're also operating the Young Adult Premium Assistance Program that Vinny mentioned. That's reduced young adults premiums in the program by about a third. So that's also, we think, had a notable impact and helped to get those young adults, who are our largest category by age of uninsured in the state, covered. And then the last item I'll mention is not a legislative initiative, but when we're considering people being underinsured, it's relevant. And the exchange convened a really productive stakeholder work group last year and came up with a set of standardized plan designs that are going to be implemented in 2024. So if you go on exchange in 2024, you'll find that each insurance carrier offers what are called value plans. And those are plans that have been designed in collaboration with our stakeholders by the exchange, that have a bunch of services covered before the deductible. They use co-pays, so you have a predictable expense that you can expect rather than using co-insurance. and they have a favorable deductible structure for consumers. So we're really trying to limit out-of-pocket costs and excited to see those launch in 2024. The exchange doesn't only support individuals who need healthcare. We also support small businesses. I won't spend too much time on this program, but I'll just let you know that after several years of challenges with staffing in the pandemic, over the last 6 months, we've been very excited to reinvigorate planning around our small business work. We have convened a work group. We are working to implement an enrollment platform for small businesses to launch in the next 2 years. And we're also working to build out additional relationships with insurance brokers. So just a last couple slides here on health equity. In 2021, we convened many work groups, convened a work group to help us explore how we could reduce inequities in healthcare coverage and health outcomes faced by people of color. The report's on our website, but it gave us some really timely and helpful recommendations that we've been working to implement since they concluded their work. Some of the things that came out of that group were changes to how we ask individuals about race and ethnicity to improve data collection and reduce the rate of people who mark others. We are also working to develop a health insurance literacy curriculum that we can share with community groups who want to provide health insurance literacy education in their community. And then the standard plan designs that I mentioned previously, we are using those as a vehicle also to achieve some of our equity goals in those value plan designs launching in 2024. We will have coverage for many services used by diabetics at $0. And we see when we were thinking about equity with this work group and looking at data that diabetes, although it's a challenge across all kind of racial groups, all income groups, does have a disproportionate impact in particular on Black Marylanders. And so by reducing the cost to maintain your treatment if you're a diabetic, we're hoping that that will help reduce disparities and encourage adherence to good care. And then lastly, just a little update on our most recent open enrollment at the exchange. We have an open enrollment period from November 1st to January 15th every year, during which anyone can enroll in private coverage. Otherwise, you have to have a special life event to enroll outside of that window, similar to if you're on an employer plan. So our most recent open enrollment period wrapped up just a couple months ago. And we saw advancement. Our Black enrollment increased by 3%, Hispanic enrollment was up 9%, and we were particularly excited to see that the enrollment of Hispanic young adults increased 13%. These are groups that we particularly focus on in our marketing and outreach. So exciting to see that progress is being made there. And in fact, our overall Hispanic enrollment through the exchange and private coverage has increased more than 20% in the past 5 years. So I think that concludes my presentation, but thank you again for the invitation to share about the exchange.
Thank you very much. Our final speaker, I'll invite Dr. Sonia Bruton to present.
Thank you. Thank you for the invitation, and thank you for the comments of my fellow presenters. I would like to begin to offer you the perspective of a Montgomery County service provider. CCI Health Services has been serving the residents of Montgomery County and their healthcare needs for 51 years now. Our mission is to deliver high quality, accessible care to all of our community members, leading the way to a more equitable healthcare system for everyone. Our vision is a healthy and empowered community for generations to come. So we are a community health center. And so some of you may be wondering, what is a community health center? Community health centers are the nation's largest network of primary care providers. We work specifically to increase access to care for all, regardless of their ability to pay. regardless of their documentation status, and we do it on a sliding scale fee. Patients and communities are come to us. We're all nonprofit organizations. Some are publicly held. We work with small businesses, local employers, and public health partners to do our work. What does a community health center offer? What do we do? We provide high quality, affordable, comprehensive, culturally competent healthcare in the areas of primary care, preventive care, behavioral health, dental, pharmacy, vision, and some of our other enabling or supportive services. At CCI specifically, our services for medical, primary care, preventive care, pediatric, family planning, women's health, infectious disease. We offer dental, behavioral health. Some of our supportive services include the WIC program and many other breastfeeding initiatives. We offer discounts on prescriptions, and we serve refugees. So for the WIC program and the Refugee Health Screening Program, CCI is the largest provider of services in the state of Maryland. We make sure that we keep our infectious disease rates low, that we offer nutrition counseling, and that we provide prenatal and support for healthy births. At all community health centers nationwide, you can find that 1 out of 8 children are being served, 1 out of 5 Medicaid beneficiaries, 1 out of 5 uninsured persons, 1.4 million homeless, veterans, more than 398,000 patients served. At CCI here in the county, in 2021, we're actually waiting on our 2022 numbers to be audited by the federal government. So all of these numbers for last year are a little bit higher, but the audited numbers that I'll share this evening, we served 78,401 residents throughout our 2 service lines. 44,000 of them participated and benefited from our WIC program, and 34,000 all of our other medical, behavioral health, dental, screening, and other services. Most of our patient populations are females, that's 63%, with 37% men. 70% of our patient base are best served in a language other than English. We are predominantly Hispanic or Latino serving organization, followed by 14% Black, 7% unreported, 5% white, 3% Asian. In terms of the coverage of the people that we serve, about 50% of them are Medicaid beneficiaries, 40% are uninsured, 7% have some kind of commercial or private insurance, and about 6% are served by Medicare. We're located throughout the county. We have locations in Silver Spring, Tacoma Park, Gaithersburg, Wheaton, Rockville, and we have a couple of sites also in Prince George's County. For our WIC locations, we're in Gaithersburg, Tacoma Park, and Wheaton. So we've been watching, supporting all of the bills and initiatives that you've heard before me, but I wanted to spotlight a few that may not seem to matter or be a direct companion or partner for the work that we do, but that we ask for your support and your advocacy. The first one is Senate Bill 187. It has to do with health occupation licenses, certificates, and registrations, specifically for those who have come to this country from somewhere else. According to our National Association's information, more than 100 million people in the United States do not have a primary care provider, and about a quarter of those are children. As you saw with our data, 40% of our patient population are children. Gaps in primary care persist due to a nationwide provider shortage, and I'll add all of the clinical support teams that work for and with those providers. This bill addresses a process for applicants for licensure and certification to be able to move those forward while they wait for the conference of their Social Security numbers. It allows them to use a tax identification number to get those applications in the pipeline. For us, that significantly not only increases our applicant pool, but it also increases them in culturally competent ways. In my previous slide, I showed you that 69% of our patient population are Latino or Hispanic. Because we are the largest provider of refugee health services, we actually serve every nationality that can be found on this globe in our locations right here in Montgomery County. So the ability to pull from and hire from clinicians and support personnel who have been trained in those countries, who know the languages, know the custom, know the course of treatment that they may have been on before they arrive, significantly improves the quality of the care that we provide. Next, Senate Bill 283 takes a look at some support around our mental health workforce. At CCI, we offer an integrated model of care. That means we treat the whole person, and we recognize that how someone thinks and how they feel actually has an impact on their overall physical health. And so this bill offers behavioral health and other services to support the well-being of our patients. We have multiple comorbidities, traumas, and other things that show up in the physical conditions that we treat and that are impacting and adding to our roles of patients who we serve just for our behavioral health services. That includes we hire clinical social workers, licensed clinical and professional counselors, psychologists, psychiatrists. The work of therapy that's done for most of our patient population, especially since the pandemic, those conditions have been exacerbated and the shortages have created even more barriers. This bill establishes a work group to evaluate and recommend programs for addressing the behavioral health workforce shortage. And as a provider of comprehensive care, we're eager to see those solutions be brought to bear. House Bill 611 really deals with an issue that we face with our nurses, our nurse practitioners, all of the registered nurses and LPNs that we have within our workforce. Without them, we'd be unable to support the care of the over 30,000 patients that we served last year. So recruiting and retaining these nurses is a challenge that affects our ability to provide access and to directly address the inequities that we find. Currently, the extended processing time that we're experiencing prevents us from onboarding and offering a start date to workers in those categories. And when renewals come to bear, it is actually taking some of our workforce off the floor while they wait, though all their paperwork has been in place, while they wait for renewals to be processed that allow them to provide direct care to our patients. Bill 611 provides an avenue for the Secretary of Health to support the board in restructuring its operation in a way that actually takes away some of the gaps and the logger jams that we're finding in the process. Finally, House Bill 283, which we hear is getting good traction. It's the Maryland Medical Assistance Program for Gender Affirming Treatment. We believe that everyone has the right to quality care. In our organizations, we offer LGBTQIA+ staff and patients and their families a professional, safe, and caring home for their healthcare needs. Last year, our efforts were recognized by the Human Rights Campaign as we were listed in their Health Care Equality Index for our ongoing efforts to create policies that promote inclusion and provide training in LGBTQ+ competent care. Medicaid currently covers gender-affirming care. However, many services are excluded, making it difficult to provide the care that reflects best practices in caring for our transgender patients. So Bill 283 will ensure that Medicaid covers all medically necessary gender-affirming care treatments. We ask you to follow us to make sure that those who are without a primary care home know about us and our services, and that you join us in supporting these initiatives.
Thank you very much to all of our presenters. I'll now turn the webinar over to Amelia Bruce for the question and answer portion of the evening. Amelia?
Thanks, Chris. And thank you to all of our presenters. That was some great information. So now we can get started with the Q&A portion of the evening. So once again, if you want to ask questions, go to the Q&A button at the bottom of your screen, type your question into the box and hit send or return. Remember that questions will be visible as they are answered. We will try to answer as many different people's questions as time allows. And we again ask all attendees to be respectful of our presenters and of each other. And remember, the program is scheduled to end at 8:30. So actually, I would like to begin with a question for any of the presenters who want to answer. This was a question that was sent to us by one of our members in advance who could not attend but wanted to make sure that this got asked. So how do you think the state of Maryland should try to budget if it were to expand healthcare coverage programs? How could it budget for the cost of healthcare for these currently uninsured populations and immigrant populations, especially as these numbers are expected to grow into the future? And is it advisable to perhaps create any kind of cap on how much would be budgeted to cover these populations?
I can start if that's okay, with Johanna and Dr. Bruden and everybody. This is an excellent question and is a fundamental question going forward. In the past, when we have sought to expand healthcare before the ACA, before the Affordable Care Act, we found revenue sources to do that. And we looked for revenue sources that had their own public health benefit. Tobacco tax increases and alcohol tax increases that reduced teen smoking and underage drinking and saved lives that way. And we've saved thousands and tens of thousands of lives with those increases. But the money that came in, we used to expand healthcare to over 100,000 people before the Affordable Care Act. I believe that the only way we're going to achieve our goal of going from 6% uninsured to 0% insured, and particularly the goal of covering undocumented immigrants for whom there's no federal money, is to find another revenue source. Our budget is tight now. It was flush with federal money, but Governor Moore is using a lot of that money for education, which is great, and for transportation and other needs, and the money's getting to be less and less. I firmly believe that the only way we're going to go forward, and we have to do this, from 6% uninsured to 0% uninsured, is to find an additional revenue source. And we are going to be looking at that. I will mention one bill that was introduced this session by Delegate David Frazier Hidalgo from Montgomery County and Senator Ben Kramer from Montgomery County. It is a bill that actually my son, Jamie DeMarco, is working on with the Chesapeake Climate Action Network, which puts a penalty on climate polluters. And according to Delegate Frazier Hidalgo and Senator Kramer, this proposal will raise $9 billion over the next 9 years. And they want to dedicate 20% of that to healthcare. That would provide the money to provide healthcare coverage for everyone. I'm not saying that's the only way to do this, but we at Maryland Citizens Health Initiative endorsed that proposal because it would provide the money in a way that would also help save the climate, which you all want to have happen. Whether it's that or some other new revenue source, we have to do that going forward. And we at the Maryland Citizens Health Initiative will work very hard to find a revenue source that will enable us to go from 6% uninsured to 0% uninsured.
I would just add to that. Thank you, Benny. I support, and part of the Healthcare for All initiative, all of those directions of looking and what's been done in the past. What I would say, it's going to be equally important that when those dollars are budgeted, that they are pushed out in a way and used in a way that incentivizes prevention. Because if we can prevent the escalation of conditions, that in itself contains costs. So part of the rising cost of healthcare, what makes it rise exponentially is having comorbidities and having untreated conditions that are caught in their later stages and require more expensive interventions.
Great, thank you. That gets to a question of my own I wanted to ask, which was, is there kind of a, are there certain programs or bills on the table right now that the panelists see as having maybe the best chance of succeeding to give coverage to more people in Maryland? And if so, why do you think those particular efforts could work? Is there a way that they are written that they account for, maybe like you said, Dr. Bruton, are more preventative rather than treating or reacting to new care needs? Or is it because of maybe the political environment we're in that you think those bills or programs are more likely to succeed?
I can start again if you'd like. And first of all, Dr. Bruton, thank you for all CCI does and for being part of our coalition. And federally qualified health centers like CCI are just critical in keeping people healthy. I think this session, we are going to see enacted, there's several great measures. One by Delegate Lord Charkoudian from Montgomery County and Senator Malcolm Augustine from Prince George's County, which will get automatically enrolled in Medicaid, people who are now on the SNAP or formerly food stamp program, eligible for Medicaid, but not yet enrolled. We did focus groups, which showed that there are many people in this state, and I think probably in the whole country, for whom, first of all, who are eligible for Medicaid and not enrolled because, number one, they don't know about it. We just assume people know about it, but they don't. People are very, very busy. And a lot of times when you're lower income, there's so much beating down on you from so many different directions. It's just hard to know that this free healthcare is there. You know, their food SNAP is there because you need to eat, but you don't know there's also Medicaids. And also these enrollment processes are barriers for people. Our focus group showed that there are people, for many reasons, there are just barriers, and we don't want those barriers to be there. So this simple law, which will say, if you're on SNAP, we have your information, we know you're eligible for Medicaid, you're not enrolled, we will enroll you. Doing that, we estimate will enroll in our Medicaid program 65,000 people. That will be a big step forward to going for 0% uninsured. Also going to pass this year is a bill to continue the subsidies that Johanna talked about in great detail. Senator Brian Feldman of Montgomery County and Delegate Ken Kerr of Frederick County. There are 17,000 young people who, even with the Affordable Care Act subsidies, could not afford their health care before these state subsidies were enacted. Now they are there. They are enrolled. Because we're continuing this program, we will keep them enrolled, and we want to make it permanent after a while. It's great. And then finally, the bill that we all talked about that will remove, we hope, immigration barriers. This bill is very, very important. We thank Delegate Cullis and Senator Lamb for pushing it forward. This bill will authorize the exchange to get the federal waivers necessary to allow folks who have immigration barriers to get into the exchange. We're also going to study how to get them into Medicaid. But back to what we talked about previously, it's not going to really work till we have the money. From I suggesting a new revenue source to cover them.
I will add that, I agree. And I think that in terms of, how the bills are doing, I am going to rely on Benny and his knowledge and his tracking to know what might be possible and what has the best chance. What I can say is what will have the greatest impact is that coverage. So right now we have a little bit of a test case in that the public health emergency is ending, and through that emergency, we had a lot of safeguards that kept people covered. And now those safeguards will go away, and we have to redetermine eligibility and re-enroll people in their coverage. And we expect that to have a pretty drastic effect on the health and well-being of the citizens in this county. And so any effort that auto enrolls, we saw that during the pandemic, that kept people covered. We had record numbers of people covered, and they used that coverage. And we saw the benefit of it in this county with people staying healthy. You know, we have had tremendously better stats throughout this pandemic than other counties throughout the state. And so it is critical that there be the opportunity for people to be enrolled and for barriers of enrollment to be taken away. And the best way to do that is to remove them altogether by making it happen in companion or in partnership or collaboration with things that they're already engaging with. And so I agree wholeheartedly. And I would say, you know, also making sure that every single resident of the county is covered, whether they're documented or undocumented, because the reality is, and if COVID didn't teach us this, nothing will. Diseases, public health conditions, illness doesn't care. You know, if it's in our community, we are all vulnerable. So keeping everyone in the community healthy is in the best interest of each of us.
I'd like to build on two things Dr. Bruton said that are very, very important. One is the successes in Montgomery County. Congratulations, your county. I want to praise your wonderful county executive, Mark Elrich, who's really a wonderful man and has done a great job, including helping us to get some of our statewide legislation passed in all these areas, especially prescription drug affordability. But also you brought up the very important point of the ending of the public health emergency. Very, very important point that people have been automatically kept on the Medicaid rolls and now are going to not be automatically kept on the Medicaid rolls as the emergency ends. This new bill by Delegate Charkoudian and Senator Augustine, in addition to helping us find the new people who were on SNAP but not on Medicaid, will allow the Medicaid department to automatically renew people who are on SNAP and already on Medicaid. This is very, very important. It is a critical way to overcome the obstacle that Dr. Bruton talked about so well that's going to happen when the end of the public health emergency happened. And this bill, Senate Bill 26, House Bill 111, has passed the Senate, passed the House, and it has to go to final way. And I'm pretty confident the governor will sign it. I think it will go a long way to meeting that issue that you raised, Dr. Bruton.
And I'll just add, since the public health emergency was brought up, which is a really good point, that, you know, I just want to say from the exchange's perspective, we're very mindful of that. We're working closely with the Medicaid program. We are planning to, you know, we're working on our planning to implement that SNAP auto enrollment, because, you know, that I agree with everything that was said about making this as easy for people as possible is critical to getting people into coverage and keeping them in coverage. We're also working, this isn't a legislative initiative, but administratively, we're working for people who lose their Medicaid eligibility if they don't self-select and enroll into a private plan, to automatically offer them a private plan to, again, simplify that transition in coverage. So if they happen to feel overwhelmed by their choices, we'll help them out with that and try to make that as simple as possible. So definitely kind of keeping a close eye on this and planning lots of outreach and efforts to ease this transition.
Thank you. That kind of leads into the next question, which is what are what are the sort of health coverage information and educational gaps that you see in that in a community organization, maybe not necessarily only dedicated to healthcare, like the League of Women Voters or other community groups as well. What are some gaps that community groups could help to close by sharing information, or, you know, making sure that members of that organization know about when they can enroll, or when they should enroll, when they should double check, you know, that they're still enrolled in a program, and you know, and also why it matters that these, especially these emergency programs and waivers and things, have come to an end. Because we've kind of, it hasn't, I don't think it's been set out right, but it seems like what the presenters have shared tonight is that part of dealing with healthcare in this country is you have to be accustomed to the culture of checking habitually and just kind of being on top of all of the information that comes with healthcare coverage. So just wondering if there is a role that community organizations can play in filling that educational need.
Well, I'm happy to start on that one. So I think, you know, certainly, yes, and we have what we call a navigator program, where we partner with organizations around the state to have boots on the ground that can attend community events. So I think, you know, one option is, if you're ever having a community event, we're happy to have a navigator attend that and do outreach to members or folks in the community. At a bigger picture, as was mentioned during the public health emergency, no one was terminated from Medicaid. And so that's changing starting next month. And over the course of a year, normal terminations are going to resume. So the Department of Health and the Exchange are doing a big outreach campaign, trying to spread the word that this is happening, and that it's very important that everyone who's on Medicaid make sure that their information in Maryland Health Connection is up to date, so that when we reach out to them, we have their correct contact information, and they'll get the notices that it's time for them to come in and renew their coverage. So we have materials on our website. We have digital items that individuals can post on their social media, and I'm happy to, any kind of community group that wants to help us spread the word, we can connect to our marketing department and they can facilitate that. And then just generally, I think one thing that's important to know is that you can enroll in Medicaid at any time. So if anyone who's Medicaid eligible should come to Maryland Health Connection and see if they can enroll. If you make too much to qualify for Medicaid and you qualify for a private plan, you can only enroll during our open enrollment period, normally from November 1st to January 15th. But Maryland, because we have this new in the last few years, tax time enrollment program, gives you a second bite at the apple. So if you're uninsured, you can check a box when you file your taxes up till the tax filing deadline to indicate you're uninsured, and you'll get another chance to enroll. So that really gives you about half the year to get into coverage if you need it. Outside of that period, if you move, have a baby, get married, have any normal big life event, you can also use that to get enrolled. So, really, if in doubt, come to Maryland Health Connection and try to get covered. It's the message we want to put out there.
And I will add, at CCI, we actually employ 2 full-time positions to be patient navigators. And that role is not unique to CCI. So when our navigators are working with a Montgomery County resident, they're working with them to see if they are eligible for coverage and getting them signed up and allowing them to then take that care or sign up for care with any provider that they want to have their care provided by. And so we're always looking for places to send our navigators where people or masses of people or people who might be eligible congregate. And so we send them to our WIC locations because that is already a population that qualifies for benefits. But we're going to be sponsoring some weekend and community events, because we want to make sure that people are redetermined, that their eligibility and coverage gets re-enrolled. And so we're always looking for partners that have access or are either a part of organizations themselves or own businesses where there is a high flow of traffic. We're happy to send our staff out there so that we get the word out, and anybody who is eligible for coverage gets that coverage, because we talked about the impact for residents, having that care and coverage so they can go and access whatever level of care that they need. But for us as an organization, I showed you on the slide, 55% of my patient population are covered by Medicaid. If that number drops by even 3%, what that does to my ability to have the resources that I need to operate my organization is felt pretty strongly. And so the ripple effect or the impact of lack of coverage really impacts all of the care that we can provide in our organizations and others like mine who have a large percentage of their patient population presenting with that form of payment. It means that that form of payment gets taken away and that revenue source does not come into my organization.
Great, thank you. That's a really interesting point that I hope if we have time, I want to get back to, but is your center also planning to do maybe any pop-up clinics or outreach or care in parts of Montgomery County where there is limited transportation, or there's limited public transportation, or perhaps in the ag reserve area of the county where it's just more difficult for people to get to a provider themselves?
Thank you for the question, Amelia. It's a great one. And what I can say is that we recognize the need. And so we've done the reverse. So we have partnered with Lysk, which is the parent company of Uber. And we actually have a partnership and a relationship with them where they allow us to offer rides to and from any of our location to anyone that needs them. And we're able to do that to meet the full need. And so we've been able to do that without a cap. And so what we do is we're unable to go out and do a lot of pop-ups. It's hard for us to time that well and to make sure that the resources are accessed when we make them available. And so we do the reverse. We make sure that anybody who wants to come to any of our locations for care, we bring transportation to them.
Great, thank you. So another question that we had was, we know that African Americans have much higher rates of fetal and infant mortality and maternal morbidity or mortality. Are there any bills either mentioned tonight or others not mentioned tonight that the panelists are aware of that are meant to address these disparities in maternal and infant health as we are reaching a point where, unfortunately, the mortality rates are significantly higher than they have ever been or have ever been for developed countries?
That is an absolutely excellent question, and it is really tragic and unconscionable that there are in my own city of Baltimore City and in Montgomery County, I'm sure everywhere else, zip codes that are within a few miles of each other with dramatically higher mortality rates in the predominantly African-American area, the predominantly Caucasian area. And that kind of data is what helped influence the Maryland General Assembly a couple of years ago to enact the Health Equity Resource Communities Act. The Health Equity Resource Communities Act, Senator Antonio Hayes, Delegate Jazz Lewis. That law is in place now, and what it does is it provides money through the Community Health Resources Commission to fund community-based local efforts to address these problems that the questioner asked about. And so far, the commission has awarded 9 of these to what's called Pathways grantees to, for example, one of them in Baltimore City, based at the GBMC hospital, is working hard, and we're helping them do this to reduce diabetes rates in a couple of zip codes that have high diabetes rates. And they're really getting doctors right to people and working to get food to people who need it, and training on physical exercise and everything else. And we work with faith communities, NAACP and others to get that message out. So this law is going to ramp up in about a year to have a lot more money available for these community-based entities to address health inequities. And we're hoping that that will help address the problem you raised so eloquently.
Thank you. I also want to ask, as a kind of a point of clarification, for families that have a mixed residency status in Maryland, if perhaps the parents are undocumented, but the children are naturalized or legal citizens, natural born citizens, are there still ways that uninsured people can perhaps still, find or get coverage for their mixed status relatives or children? I'm wondering if this is an area where people may not be aware of what they are eligible for or what their families are eligible for in terms of getting care.
Yeah, I'm happy to address that, and that's a great question. So yes, mixed status families can come to Maryland Health Connection to enroll in coverage. For example, if parents are seeking to enroll their children, they can do so. The parents don't need to provide their immigration information to enroll their children. So there shouldn't be a concern there. They can get the kids enrolled or other legally present family members.
Thank you. So is there currently any effort in Maryland to bring down the rising costs of healthcare, including hospital costs, insurance costs, medical practices, kind of in a similar way that there are some efforts at play to bring down housing costs and rent costs as a basic cost of living? Either maybe not in this at the state level, but perhaps at the federal level that any of the panelists are aware of.
We have found that one of the most significant cost drivers is high prescription drug costs. And that has been a problem for years, and it's getting worse and worse. And Maryland is taking the lead in the country with our Prescription Drug Affordability Board, which has the authority now, and will be using it to put an upper payment limit on what state and local governments pay for high-cost drugs. And high-cost drugs are really hurting state and local governments, as your own county executive, Mark Elridge, says so eloquently all the time. And we hope to pass legislation next year to give that board the authority to make high-cost drugs more affordable for all of us. That's a very, very important way to make high-cost healthcare more affordable. And I want to praise President Joe Biden again in the Inflation Reduction Act, which has those additional subsidies I mentioned earlier for people, also for the first time allows Medicare to negotiate with the drug corporations to keep costs low, and has provided insulin cap on what people on Medicare have to pay for insulin. And thanks to Chair Delegate Jocelyn Pena-Melnick, there's a cap for Marylanders also of $35 per month that pay for insulin. And also under the Inflation Reduction Act, starting in 2025, people on Medicare will never pay more than $2,500 out of their own pocket every year for their drugs. So one of the best ways to deal with this high-cost healthcare is to make high-cost drugs more affordable, and Maryland's leading the way on that.
And I can share from where I sit, we have a lot of programs that come federally to try to keep the cost down. It is what allows us to see people regardless of their ability to pay, and to offer discounts for those that we find who are uninsured and who are underinsured. And what that means is you may have a commercial product that has a deductible that's too high for you to meet. And so we assess everyone who comes in for care to make sure that even if they are insured, if they're due a discount, they get that discount. But we are able to participate in a federal program called the 340B drug pricing program. And what that does is takes those costs that Vinny was just talking about and really removes them by allowing us to get the same cost for the medication that the federal government pays. And we get that for drugs that we have on hand for our use, but we also get to pass it on to our patients. So any of our patients, when they get a prescription and go to fill it at whatever pharmacy that they use, we have contracts that allow them to fill that prescription out of the 340B stock and to pay that 340B price. Other costs that inflate the cost of care for us, lab fees. We have to negotiate pretty hard to make sure that lab fees stay affordable. For us, when we provide a medical visit, it includes labs without having it be an additional cost. So whatever labs that are run, we pay for that as part of the regular price of the visit. Any of these bills and these efforts to provide coverage provides the resources to pay for all that and pay for it in one lump sum fee. So we get one lump sum for a Medicaid beneficiary, one lump sum for a private insured patient. Anybody we negotiate to receive one lump sum payment. And so as many of those costs as we can keep down, the less that others have to pay, namely for us, by having that person have to access more expensive forms of care. If we can't serve them in our setting, they're going to go to the emergency room, and that's the highest form of care, no matter what actions are taken, than any of the other forms of visits.
Great, thank you. You mentioned the underinsured. Are there other sort of characteristics that that the industry uses or that runners of the exchanges and things use to determine who is underinsured versus uninsured, and why it matters to make that distinction?
I'll start with that one and then let the insurance piece pick up. So if you can imagine, so the way that underinsured is categorized in my setting is based on household size and household income. So we have a chart that says, based on your overall earnings, your annual income, we take that number and use it to form a list of charges that then look at how many people live in your house and versus how much that you make. And so that then tells us what you can afford. And so if you think about it, just in the cold and flu season that we just got over, I might be a mom with 4 kids and all of us have coverage, but there is a deductible for all of those policies. And so if I and 2 of my children have the flu and we need to come in to get a rapid flu test to confirm that so the right medication can be given, if you haven't met your deductible, the full cost of that visit, and for me and my organization, if it's a primary care visit, which a flu visit would be, that's $289. That's what it costs me to provide that care. That's no upcharge. That's my total cost. I have to charge that to you for you and 2 of your kids. And so if I take that $289, or we'll just round it up to $300 just for easy math in my head, that's $600. And, I challenge you to find any income bracket where that's an easy outlay that you hadn't planned for. And in some of our lower income households where their earnings are low, they have a job that provides them a benefit, but they're still making low salary. And that benefit that they're given comes with money they have to put up first. They have to pay that deductible before the insurance kicks in to pay any portion of that care. That's not doable for many households. And so you have insurance, but it's not helping you. You still can't afford to be seen. That's how we determine, and that's what we classify as underinsured. It doesn't provide payment for the services that you need when you need them. And so for that household, many of these plans, these commercial plans, sometimes that deductible can be $2,500 or even up to $5,000. And for some households, they'll never reach that. That even if they only use it for sick visits throughout the year, their payment of $2,500 or $5,000 per family member really means that they don't have any coverage at all.
Yeah, and I can add to that at the exchange, I wouldn't say we have a working definition of underinsured, but it certainly is a problem for many individuals. For folks who are below 200% of the federal poverty level, which is about $25,000 a year for an individual, about $60,000 for a family of four, there is substantial financial assistance to reduce your deductibles and how much you have to pay when you're getting care. If you're over those levels, we as a state don't have any financial assistance through the exchange to reduce your out-of-pocket costs. Other states have found funding sources to do that, and that is one potential opportunity in the future to address that issue.
Great, thank you. There was a question as to the earlier point about finding a new revenue source for supporting healthcare coverage. Is a possible revenue source perhaps a new higher taxes on upper income earners, or perhaps a tax on specific products like high sugar beverages or any other sort of products? Are any of the presenters aware of ideas floating around like that as a revenue source?
Those are two really good ideas. I know there are folks in Maryland, sugar-free Maryland, working to increase the tax on sugar-sweetened beverages. I think that's a really good idea, because you do that, you reduce diabetes and other problems caused by kids drinking too much soda, just like you reduce teen smoking, saves lives, and these are life-saving measures. For us, one key factor is what is the politically most potent revenue source that the public would strongly support, that would help us get the money we need to expand healthcare coverage. And we hope to get the funds to do some really smart public opinion research, maybe polling, focus groups, to really test all of these different potential funding sources and find one that the public really supports. And that would help us get the legislature and the governor to support it and get it enacted. It's not easy to raise revenue sources, because when you do, our public health revenue source is a tax to somebody else, right? Is to somebody who, if you're the alcohol companies, you hate alcohol taxes, tobacco companies hate tobacco taxes, soda companies hate soda taxes, and they have a lot of power and they would fight very hard against it. And if you tax millionaires, the millionaires fight very hard against it. So you have an enemy there that you have to fight, but it's worth it if the public is there behind it, so we can overcome those obstacles and get the money we need to achieve all these goals of going from 6% uninsured to 0% uninsured, and do what Johanna said, is covering people's deductibles, and so that people go see Dr. Bruton can really afford the healthcare they need. We commit to everyone here that we will do everything we can to find that revenue source. It won't be easy, and when we start working on that, we hope everybody will be with us to make it happen. Thank you.
Thank you. So are there any initiatives in Maryland right now to reduce the disparities of accessing care for behavioral health issues especially disparities for people of color. The question submitter notes that the American Psychiatric Association has reported that African Americans are often misdiagnosed or overly medicated for psychotic disorders. At the same time, there is a sort of national crunch for mental health care and mental health services. So are there any legislative efforts in Maryland right now to try to address that problem?
That is not something I know a lot about, but I do know that Maryland Senate President Bill Ferguson, who's a great public health leader, has a package of measures designed to address behavioral health and address problems like this. And I think that he's working closely with Mental Health Association, behavioral health groups to do something this session specifically on improving Maryland's behavioral health system. And I know that our wonderful new health secretary, Dr. Laura Herrera Scott, is committed to improving behavioral health in Maryland.
Thank you. We are coming close to the end of the evening. I want to see if I can ask one question that might be a big question, but hopefully yield some good answers. So I was wondering if the presenters can kind of explain why it's necessary to take legislative action to close healthcare coverage gaps at both a federal and a state level. What are maybe examples of things that can be done at the federal that can't be done at the state and vice versa? Or what is the sort of symbiotic relationship between these two levels of government that are necessary to close the gap in healthcare coverage for the uninsured, for immigrants, for refugees, and for low-income earners?
Well, we don't make progress in healthcare without legislative action and without advocacy. I mean, we began in America really moving in this direction with Medicare in 1964. Before that, senior citizens didn't have any healthcare coverage, and now they did with Medicare and the Medicaid program, which was also enacted in 1965. And really the biggest expansion of healthcare in America and in Maryland happened with the Affordable Care Act, President Barack Obama's landmark law, which reduced the number of uninsured in America by 20+ million people. Tremendous progress. And then the Inflation Reduction Act, President Biden, Vice President Harris, has helped millions of other people get coverage. So this is necessary. And we in Maryland, as I said earlier, made some progress before the Affordable Care Act, but we could not have gone from 13% to 6% uninsured without the Affordable Care Act. At the same time, the Affordable Care Act is not enough because some states did not fully implement it. We did. We have the tremendous exchange, and we have a bipartisan support for doing that. We are making progress. We need to go further in Maryland, and I laid out earlier the measures we want to enact in 2023 and beyond to achieve Governor Westmore's goal that he said in his inaugural address, leaving no one behind in healthcare in Maryland, and we will do that.
And I will just say, we are a federally qualified health center. That is a federal legislatively mandated program, and it exists to form the safety net. And so we have existed, my organization and organizations like ours, to make sure that there is a service provider who will provide care to anyone, regardless of their residency status, their language skills, their income, their literacy levels. We have mandates that puts in people and programs to address each one of those pillars, because we know that if any of them are lacking in any way, healthcare quality suffers. You add to that companion programs of a loan repayment program that allows us to hire professionals and have them come to us, earn their full market competitive salary, but also receive tuition reimbursement, loan repayments. So there are, at the federal level, there is a whole system of care that has been created through legislative means. And what that legislative means gives us in terms of protection is just the stability and the continuity. To undo the program, you have to remove a bill, remove this legislation, this supported legislative program in our landscape. And so it adds that extra layer of protection. When at the state level, as a companion to that, these initiatives that receive legal protection and resources, what they do is that they ensure the stability of them and the longevity of them. And that's what's required to make systemic change through populations intergenerationally. One of the question askers earlier was pointing out the difference in the disparities that exist around birth and mortality, and especially with African Americans and our birth rates in terms of full-term healthy babies. And I know that one of the things that we do, we have many programs that are designed to make sure that there's culturally competent care. We know that evidence-based medicine and the research shows that having a provider who looks like you and comes from where you come from changes the listening, changes the course of treatment, and therefore changes the outcome. And what I will say is that in this county and the counties that we serve, we struggle to get African American patients coming to our doors, and we don't know where they're going, and we don't know what keeps them coming from us. We just received a grant from the state called Thrive by 3 that we're targeting the African American community for our prenatal programs and for our early childhood programs. And we struggle to find folks to enter those programs. And so I think part of it is an awareness issue. And some of what happens when things are done legislatively, it gets the word out to a broader spectrum. And so there are many benefits that come from things happening at the will of the people, which is what representatives do. They represent us and then carry out our will. And so there's also that extra scrutiny that goes behind them and the listening. When Vinny talked about part of the way that a revenue source is going to be found to fund some of this stuff is to hear what the will of the people is. So one of the things that the women who are listening and their allies and friends and everyone else who's partaking can do is make their will known. Think about, after this conversation, what are you willing to give up? What are you willing to pay more for to address these inequities in our healthcare? That's the first step of us finding what that funding stream will be, is to determine it for yourself and then communicate it and then rally around it and support it.
We're running out of time, but I want to let Johanna have a word, a couple of minutes before we close.
Well, I'll just add that, I think legislative action in the health sphere is really critical, both in the past and will be in the future. The Exchange and Maryland Health Connection are a product of the Affordable Care Act, which was federal legislation, and also of state action, because the state decided to create its own state level exchange. So there was a requirement in the ACA that a state have an exchange. They could either opt into the federal platform or they could create their own state specific one, and Maryland chose the latter. And because of that, we have the benefit of being able to do the things like the SNAP enrollment into Medicaid and the young adult premium subsidies. Those wouldn't be possible if we were on the federal exchange. It's much less flexible. So having the state-based marketplace and having the state decide that they wanted to take control and kind of opt fully into the Affordable Care Act options really has given the state a lot of opportunity now and going forward. So I think, there's ways that action at both levels are critical and opportunities at both levels of government.
Thank you. That's all the time we have tonight. Thanks to all of our esteemed presenters, all three of you. Thank you very, very much. And to everyone watching tonight, if anyone watching enjoyed this free program and wants to learn more about the League of Women Voters of Montgomery County and our work, you can find out more about us, including how to support our efforts at LWVMOCOMD.org, LWVMOCOMaryland.org. With that, we will say thank you and good night to all.